Morning, everyone. While the AV system starts working, I'll just sort of start my talk so we keep to the time. My name is Sachin Salvi. I'm one of the ocular oncologists at the Royal Hallamshire Hospital in Sheffield. It's great to come here and speak to you all after, I think, 3 years. 2012 is the last time I was invited to come and speak to you all, and it's a great opportunity and an honor. I think this probably one of the best things is to be able to communicate to our patient group, to try and sort of discuss with you what treatment options, what things as medics we like to do for you, or we're trying our best to make sure you get the latest treatment, latest follow-ups and care plans, but also a great opportunity for us to learn from you, how we can do things better. It's a lifelong learning process for me as a medic, and I'm hoping we can continue this interaction for a long time to come. Okay. Is there any way I can forward without, forward just on that? Okay, yeah, it's fine, great, no worries. So, as I said, I'm one of the oncologists in Sheffield. I'm going to base the next 25 minutes of my talk on 4 main areas. So I've been asked to talk about the Sheffield approach to ocular oncology, and I've just literally taken those words. I'm going to tell you a little bit about Sheffield. I'm going to tell you a little bit of ocular oncology, and I'm going to tell you a little bit about how we approach it, okay? And then one of the newer evidences that has come out, or with a lot of work that has gone into the Uveal melanoma guidelines. And I'm going to tell you a little bit about the guidelines, and perhaps, if I have time, how we are trying our best to conform to the recommendations. Okay? So a bit about Sheffield. We all know there are 4 ocular oncology centres in UK, Sheffield, Liverpool, London, and Glasgow. At Sheffield, we have 3 consultants, Prof. Rennie, myself, and Paul Rundle. We also have a clinical fellow, a big research team, an associate specialist, and we're very lucky to be supported by our nursing team. We get patients from sort of not just the north of England. We get patients right from Devon, south, further down south, Northern Ireland, occasionally from Greece, Trinidad, Tobago. So we have patients traveling all the way with our links that we've developed over the years with these centers. Ours, we are really proud, and we value the fact that ours is a consultant-led service. We ensure that every new patient gets seen by one of the 3 consultants. If the associate specialist or the clinical fellow sees them, we still give our input, make sure that everything's been discussed with the patient. To give you an idea, we all run a new patient clinic on which perhaps each one of us would see at least 7 patients. So we've got 21 slots. Occasionally, we get many more referrals per week than those, and we have extra clinics and capability to see these extra patients. You all know how important counseling and support is for patients who are diagnosed with cancer. And we have Rona, who has kindly come along with me today, and Leslie. Rona is actually the first Macmillan ocular cancer trained nurse specialist in the world, really. And she's been doing this job for, 30 years? 20, sorry. Sorry, I was going to say 10. So she brings a vast amount of experience, really, with the fact that she knows exactly what the patients go through. And we really pride ourselves on giving that personalized touch to our patients. We also are proud of the fact that we have a weekly MDT. So every Tuesday morning, all consultants, the whole ocular oncology team, including the histopathologist, once a month the liver surgeon, radiologist, we all meet together and we discuss every new patient. Each new patient gets discussed. The consultant who's seen it will discuss his plan. The other consultants will give their feedback, and that is then fed back to the patients about what the decision was. So you not get one consultant's opinion, but you get a whole team's opinion about not just the diagnosis, but the management and further pathway. We believe in shared care pathway. Really love the fact that we interact with our patients, the fact that we involve them with the management of the treatment. And I'm proud to say that Sheffield's probably, and I say probably, the only place in the world where all treatment modalities are offered to the patient. If you look around the world, if you go to any center, each center will have one particular modality they will prefer their patients to be treated with, be it stereotactic, be it proton beam, be it ruthenium, palladium, be it iodine. But no center will have capability to offer all the treatment modalities in one place. We've also started a fellowship program. My last fellows moved on to Sydney. We've got interest from other international fellows and fellows wanting to train because of the care we give and the treatment modalities we offer. We also believe in a lot of training, so every couple of months I'll either go to Manchester, Nottingham, Birmingham, Leeds, and we'll teach our ophthalmology colleagues. We'll talk to them about ocular melanoma. We'll talk to them about how to pick these quickly, what treatment modalities we have. And we build very close links with our ophthalmology colleagues, which enhances our pickup, and we're able to see our patients quickly and give them the treatment options. And obviously, over the years, we built great links with OcuMel, and which I'm very grateful for. So that's the team. That's Prof. Rennie, Paul Rundle, histopathology, and our main two support system, really. That's Rona and Leslie there, with Karen Sisley, who's our research nurse. So hopefully you've got an idea about what we do at Sheffield. I'm going to talk a little bit about ocular oncology, or what ocular oncology or ocular melanoma means to me. I was asked Sheffield approach to ocular melanoma. So by ocular melanoma, I know most of you think about is a uveal melanoma. But as a surgeon trained in ocular plastics, which I deal with lid cancers, orbital surgery, which I deal with orbital problems, and lacrimal surgery, I'm able to not just treat patients with intraocular melanoma, but treat every patient who has melanoma, be it on the eyelid, conjunctiva, uvea, or orbit, okay? And I know if you think about it, uveal melanoma, you say 5 in a million. If you look at conjunctival melanoma, you start going at 1 in a million. And you look at orbital melanoma, you start going at 0.2 or 0.3 in a million. But all these patients do come to us, and we're able to give them the latest treatment based on latest evidence. I'm going to show you some images, because just to show you the variety of ocular melanomas we treat. And if at some point you feel, there's one particular image, I'm just going to give a disclaimer. If you feel you don't want to watch it, just look away. So eyelid melanoma. So melanomas can happen in the skin. So obviously they can happen on the eyelid, okay? So you can get them on the upper lid, you can get them on the lower lid. There's a big study we're doing at melanomas which actually involve the lid margin, because what we see is actually a spillover onto the conjunctiva, or rarely conjunctival melanomas which spill over onto the lid. And there's not much known about these things. We're able to manage them, but we probably got a cohort of 60 or 70 patients who have similar problems who we've dealt with. These melanomas are surgically easy to manage. It involves resection, cryotherapy, mitomycin C, and a lot of topical treatments. Obviously, each patient needs an individualized follow-up plan and a metastatic screen. There's another patient who had an eyelid melanoma, but you can't see the melanoma. But effectively, the melanoma is actually extending, it's spreading along. So it's like a lentigo pattern. It really isn't sitting up at one spot. And when we biopsied and investigated her further, we found out actually it's spreading further beyond, not just the eyelids, sockets, but further beyond. And she required an extensive surgical procedure. I've not shown the surgical procedures, but this is her after the resection, but with an artificial prosthesis. This was 2.5, 3 years ago, and she's doing extremely well, I'm pleased to say. So that's lid melanoma. You can get melanomas on the conjunctiva. This is a gentleman, 18-year-old. This is not a nevus, but the fact that it's got a tapioca appearance is very unusual. He doesn't have multiple moles. He's not a freckly person. We've done a UBM, which doesn't show deeper involvement, and he underwent resection. So we excised this conjunctival melanoma. Histologically, it confirms it, but shows that the margins are not clear. So go on to put a ruthenium plaque to treat any residual problem. That's how his eye looks afterwards, okay? Again, these patients need head and neck MRIs, lifelong follow-up, so it's again individualized to every patient. Rarely the conjunctival melanomas are bigger. So they're not just a small freckle, they actually are there's a part of melanoma, I'm sorry about the lighting, but it's part of a big nevus in which you've got a melanoma growing in. Again, a young boy who need not just excision, but an amniotic membrane graft to cover the wide area. I can't just close the conjunctiva directly. Again, he had excision, cryotherapy, alcohol epithelectomy, amniotic membrane transplant, post-operative mitomycin C, and that's how his eye is doing really. He's doing quite well afterwards. We are able to treat, well, let me show you one more slide and then I'll tell you what's helped improve our management of these. One important thing to remember is that thicker the conjunctival tumor, the breast thickness, the more chance of it metastasis. But we can manage them locally, but they just need close monitoring to make sure that they don't metastasize to head and neck, lymph nodes, or other sites. One thing that's really changed the management of these localized conjunctival tumors is use of amniotic membrane. I'm able to cover big areas of the conjunctiva and get a beautiful result with amniotic membrane. And I can discuss this at some point, which I won't go in detail for time reasons. Each one, we've got protocols and pathways how we manage each tumor. Rarely we see tumors in the lacrimal gland, and rarely we see tumors in the orbit. Okay? These are people who occasionally have primary orbital melanocytosis, other risk factors, but they do get referred to us. Just going to show you a scan, what an orbital tumor or orbital melanoma would look like. It's had a biopsy. The next slide, if you don't want to see, I'm just going to give you a few seconds to look away, look down. This is what he required. He required the whole orbit removed and an osseointegrated implant, and that's what he looks like with an artificial prosthesis. He again looks, wears goggles or glasses which hide it. He really is one of our most grateful patients. He raises money for our department. He does music shows. He plays in a band, and he loves his life. He really, so it's not, we love the fact that how we able to help him. I did his exenteration surgery on his birthday, but he said, I want to get it over and done with. That's amazing to see the fight you all give, and it's really appreciated. So I've talked about various melanomas. I'm going to quickly talk about uveal melanoma, which you know about. You've got uveal melanomas, which a number of you, I presume, have been affected by or have relatives or friends who've been affected by it. We believe in the latest gadgetry. It's like my son, any new toy, we try and get it in the department. We've got Optos, we've got enhanced OCT, we've got 3 different B scans which show you the thickness and best way of measuring these tumors. Looking at A scans showing the characteristic of tumors, and EDI, OCTs, and other instruments we use to help diagnose our tumors. So what we know, and what you probably already know, is that 99% of melanomas can be diagnosed just by these methods. You don't need a biopsy. You don't really need a diagnostic biopsy to find out. So most of you will, who have suffered from uveal melanoma, will be coming in and will be telling you, look, I'm 99% confident this is a melanoma. I don't really need a biopsy by the characteristics. Okay? So we've talked about Sheffield. We've talked about ocular melanoma, what it means to me. And I'm going to tell you about Sheffield approach in the next 5 minutes. As I say, every center is different, and that's the beauty of it, really. You get every center using their experience and reasoning why they do certain things certain way. And what is important you have to realize is no one's doing it because they're obstructing progress, but this is what we genuinely believe in, that this probably is our way and this is a good way, and we do not refute that other ways are not good, but we're open to discussion. We make sure every referral that comes to us gets seen within 2 weeks. Most of our referrals come from our colleagues, as I said, from all over, wherever really. We've got a good admin team, and all patients, new patients, will be seen within 2 weeks with a consultant input. What do you expect at your first clinic visit? You'll get all the diagnostic imaging that we talked about. You will then see the consultant who will look at the imaging with you, discuss with you, and there are 4 main things that we'll discuss. We'll discuss the diagnosis. Rarely we get patients with hemangiomas, metastasis, vascular malformations. There are a lot of other things that come as well, but I'm going to focus on uveal melanoma. So we'll discuss the diagnosis, we'll discuss the treatment modalities, okay? So, whatever it may be, and if I have time, I might come back to the treatment modalities, ruthenium plaque brachytherapy, proton beam, stereotactic, occasionally photodynamic therapy, or if none of these are possible to be done because the tumor is so big or the patient choice, then enucleation surgery. We will then discuss with the patient or offer the patient prognostic biopsy, and I'll again touch base a little bit on that. And we also discuss, or we'll explain that these tumors have a risk of metastasis, and we'll go in detail if the patient wants at that time or at a later date. But we'll make sure that the patient then goes on to see either Rona or Leslie, who will then, it's a big thing to be told you've got eye cancer. We just believe that the patient needs a bit of time, and then maybe not a doctor, but someone else they can speak to, their fears. You have lots of questions which you don't really think of the moment I tell you the diagnosis. Someone is there later on who will discuss these questions with you. We also have GA slots available. As you can imagine, most of these surgeries, except stereotactic, would need general anesthetic. Yeah, so we make sure the general anesthetic preparation is done for you. Elderly patients who need, fitness, anesthetic profiling. So a lot goes behind the scene to make sure your surgery goes on the day you need it. But most of it we try and achieve on the same day, at least baseline assessment. We also arrange an ultrasound of the abdomen. We talked about screening, surveillance. The advantage of that is we've got slots available where you come in, you're told the diagnosis, you're told the treatment options, prognostic biopsy, and we do an ultrasound abdomen too, because we know that only 3% of patients have spread at the time of diagnosis. What's the advantage? It's really, when you have a bad diagnosis, at least heartening to know that you may not have metastasis at the same time. And if you do, then we might change the treatment option. So you get a complete picture. You just don't get a picture that you've got an eye tumor. We will give you a complete picture what the risk of its spread and what treatment options and follow-up metastatic screening is. Every patient, as I said before, gets discussed at the MDT. And then we pride the fact that every patient with a tumor will get surgery within a month. I have 3 surgical theaters a week. Paul Rundle has another one. You've obviously got PDT, we've got another session for that. And we obviously extend surgical times to make sure that we meet. Last 4 months, our referrals have increased 50%. So we're just working 50% harder. It doesn't mean that you'll be waiting longer. And that's our charter for patient care, really. A lot of people ask about follow-up because treatment, as you know, is not the end all. You have to make sure that the eye doesn't get recurrence. Again, the chance of that is less than 2%, whatever treatment modality you do. We also need to make sure that you don't get radiation or problems from the surgery. So we will see you at the first follow-up. We'll see you. This is an average. Some people maybe 3 months, 4 months, but that's what we aim to do. 3 monthly for the first year, then 6 monthly for 5 years, and then yearly for up to 5 to 10 years, depending on the patient's one. A lot of patients then say, look, I'd rather get seen back in Ireland, I'd rather get seen back in Greece, and we'll share that with them. But we'll follow up, we'll do a discharge summary, which explains what to do about ophthalmic follow-up. But everyone has access to Rona or Leslie, and we're trying to develop more clinical nurse specialists who will be trained to do the same role. We know that 50% of melanomas have a risk of metastasis, okay? We do our metastatic screenings. We do a 6 monthly ultrasound of the abdomen for up to 5 to 10 years, and then yearly afterwards. If obviously we find any abnormality on ultrasound, patients would get an MRI, usually the same day, that's diffusion weighted, and then a PET scan, because we want to find out whether it's just spread to the liver or elsewhere. And then obviously we'll then discuss with our at our MDT, every met with the liver surgeon oncologist, and make a treatment plan, which is for individualized to the patient. There's a lot of debate about everyone saying every patient should get an MRI, okay? We looked at the guidelines, we're still not convinced, but we're doing a study. We're looking at ultrasound versus MRI. What's the advantage of ultrasound? We can do it on the same day. A lot of patients love the fact that I can do it the day I tell you a diagnosis, so they know a complete picture. MRI is difficult to get it on the same day. As you can imagine, it takes longer. We're doing a study whether what we find is ultrasound better at picking these tumors, or is MRI picking at these tumors. And we've done this with patients with high risk, patients who have had enucleation surgery. Recruitment's a little bit of an issue at the moment, but what we found out, we've done simultaneous MRI and ultrasound. We just haven't been able to pick up one as better. The one patient, and it's only recent that we picked it up on the MRI but not on the ultrasound. But it's tiny, really tiny spots which need another 3 monthly repeat checks. And if we find, we're obviously going to need bigger numbers, but if we find that MRI picks them up earlier and there's something that can be done with that information, then we're delighted to do MRIs on everyone. But we just need that information. And again, as I reiterate, we're open to change. We'll do what's best, but it's still early days for me to say which one's better. So we talked about what Sheffield does. We talked about what ocular melanoma means to us. We talked about the Sheffield approach. There's a lot I can do. I've just been shown the 10 minutes card. So I'm just going to, in the next 5 to 7 minutes, talk about uveal melanoma guidelines, okay? So we've got Prof, we've got Leslie here, who've all contributed to these national guidelines. It's probably the first time all healthcare professionals and patient group came together to unify, try and make sense about what newer evidence there is, what treatment modalities should be given. And as you know, it was a fantastic opportunity for me to work and interact with every member on the panel. Essentially, there's a lot we looked at, and from what Catherine and Rob have told me, from the feedback from patient group, as well as what the highlights of our guidelines were, is that patients want, and we should discuss all treatment modalities. And if a treatment modality is not available in your center, then, and if the patient wants, you should refer to another center. We talked about every patient needs to be offered prognostic biopsy. We talked about that every patient should have access to supraregional MDT, involvement of the oncologist, and that there should be an individualized plan for surveillance, okay? And I'm just going to quickly touch base on how we do things in Sheffield. We've changed over the years. We try our best, and this is my discussion or our slant on each pattern, or on each of these 4 topics. So discuss all treatment modalities. This is how the spread is in Sheffield. This is last year's figures. 35% still get ruthenium plaque, 15% will get proton, 25% stereotactic, enucleation, and some 20%. So if you think about it, the enucleation rate has dropped down over time. So we do globe preserving procedure. They may not be site preserving, but each one of them is equally effective, okay? I'm not going to go into discussion. There's a paper that in this month's Eye which we've published about proton beam versus stereotactic. We're very fortunate to have the National Stereotactic Center in Sheffield. We've not yet had patients from other centers sent to us, but it's available in Sheffield, so our patients get access to it. Anyone who's not fit for a general anesthetic, anyone who's claustrophobic, anyone who wants a one-day procedure, there are other advantages, and it's usually, quite often, we do this for patients who have tumors next to the disc, who may not have visual, who have poor visual prognosis anyway, but it saves the globe. So there are a lot of advantages which I can, over coffee, discuss with you if you want to discuss this further. But the treatment depends on the size of the tumor, location of the tumor, the health of the patient, and patient choice in the end. Some patients turn around and say, look, I've got a tumor in the eye, I want the eye removed, and we'll discuss with them, but then we'll always respect their wishes. But some patients may say, I want proton beam, and we're happy to put clips. So that's the first bit about discussing all treatment modalities, and we don't have to send any patients to any other center because we offer them all here. Second bit you want is about prognostication biopsy, okay? I'm going to spend 2 minutes on this. I'm going to ask you, or I'm going to give a scenario now. I'm going to say, imagine you've come to me at Sheffield, and I have done the first 2 bits, which I've told you about the diagnosis. I've told you about the treatment modalities, and I explained to you saying, as you know, melanoma have a risk of metastasis. There's a chance that it may spread elsewhere. If you look over various papers, it says there's around a 50% chance of it spreading elsewhere. We have the opportunity to offer prognostic biopsy, which will tell us if the chance is any higher or lower. And we can discuss that. Is this something you would want to consider? How many of you, put your hand up, would want to know prognostic biopsy, please? Yeah, perfect, great. So I think we've already seen that we've got more than half, but not everyone wants prognostic biopsy. Again, the reasoning why you may want prognostic biopsy is because, I'm going to skip one slide and tell you a little bit about it, is because you may want to change your lifestyle. So if you've got high risk, you may want to change your lifestyle. If you've got low risk, you may feel, well, it's low risk, okay? So what do we do in Sheffield? Okay, I'm going to tell you a little bit about what to do in Sheffield. Well, Sheffield's one of the first centers where biopsy was done, believe it or not, okay? There are lots of papers on it over 25, 30 years. Publications about transvitreal biopsies by Prof. Rennie, looking at chromosome analysis. The first paper about chromosome 3 being a bad prognosis is from Sheffield. But what we've realized is that over the years, it's not as simple as that, and I'm going to come back to that. I, working on the guidelines, realized that, look, a patient really wants prognostic, a number of patients want. I spent a month last year in Cleveland with Arun Singh, who's one of the main oncologists in the world. Improved my skills on transvitreal biopsies, on transscleral biopsies, got his experience. We've written a lot of research papers about, on these topics. I'm not going to go in detail but I took a month away from my work and spent to learn more. What I'm going to tell you about is what happens when you say, whether you say, if you said you don't want to know, then I'll say, we'll be doing 6-monthly screening anyway, whether you're high risk or low risk, okay? Whether you want to know or not. If you want to know, then I'm going to tell you a little bit of the advantages. And the advantages are obviously that I said 50% would have risk of metastasis. Biopsy, it's not 100% accurate, but we could tell you if the risk is 80%. Various papers will quote different things. This is what we've experienced and what our generalized idea of the picture is. If you have low risk, then the risk is 20%. It's not zero, mind you, it's 20%, but the advantage for you, if it's high risk, then you can plan your life accordingly. Some people believe that if you're high risk, then the monitoring should be more frequent or could be more frequent, whether it will be picked up earlier. And the belief in some patients is that, well, if I'm high risk, if a trial comes on later, I might be eligible to enter into that, okay? What the advantage is, again, so you've told me, I'll tell you that there are advantages, and that's because I can tell you whether it's 80% versus 50% if you're high risk, or 20% versus 50% if you're low risk. I also have to tell you that this test is not 100% accurate. So if you're high risk, doesn't mean you'll get metastasis. And if you're low risk, doesn't mean you will not get metastasis. We're talking about 20%. So 20% of my low risk patients still get metastasis, and that's years down the line. Also remember, there's risk of false negativity. So if I do a biopsy, there's a chance that I may not get the tumor which shows the negative or monosomy 3 or other genetic abnormalities. So false negative means if I tell you that you're high risk, then you are high risk. Okay? If I tell you that you're low risk, that means you don't have bad genes. There is a chance that I may be wrong because I've not sampled the tumor where the bad genes are. Okay? So that's not 100% accurate. But we can also tell a lot of information on the tumor, so that's called heterogeneity. We also know that a lot of these tumors, depending on the size, shape, location, extraocular spread, invasion of the sclera, invasion of the retina, I can tell whether it's high risk or low risk. Also, when I do biopsy, especially of the smaller ones, or any one for that matter, there's a 1 in 5 chance you may not get adequate sample. There are risks with biopsy, and it may be local spread, because you can imagine you're taking a sample of the tumor, say imagine a 2 millimeter sample, the bevel of the needle is 2 millimeters, and we've seen patients who years down the line have had biopsies but developed extraocular spread because easy for the needle to go from the biopsy site into the orbit, and we presented that at the World Oncology conferences. So there is risk, it's not risk-free. There's also a risk of complication of biopsy, retinal detachment, hemorrhages, as well as scleral melts. And what does happen is that there's a risk of, if you think about a conjunctival melanoma, if you touch a conjunctival melanoma, you want to remove it completely without biopsy. And I don't know if that's the gospel in conjunctival melanoma. You don't touch the tumor. You remove it completely because you 5-fold increase the risk of metastasis if you touch the tumor with a biopsy rather than excising it completely. And I'm not saying it's the same with pleomorphic adenomas in the orbit. And I'm not saying it's the same with melanoma, but something to be aware of, that you're actually converting a pseudoencapsulated tumor and exposing it to blood cells. We don't know whether the blood cells will carry these biopsy specimens elsewhere. This is speculation, but I have to warn you about it. And also, I want to know, how will you take it if I tell you that you've got a negative biopsy? A number of patients want to know the information because they're hoping it's it's good news. They're hoping that they don't have high risk. How would you take it if I told you that you've got an 80% chance of metastasis, say, within the next 5 years? Some people will be fine, but what we find is a number of people just break down. They just don't like that information. And so they regret having it because they just increases the anxiety. And I'm not saying everyone does it, but this is individual to patient. And some centers will do surveillance only on high-risk patients. We do surveillance on every patient. So every patient with a high risk or low risk will get surveillance. And that's because 20% chance, even if you're low risk, that you'll spread. And the last bit is that adjuvant trials, I'm hoping, will come. Yeah, and I am pretty sure they'll come soon, and we should be able to start treatment with chemotherapy, but they're not available yet. And what we know is that anyone, whether you've had a biopsy or not, before the start of the trial will not be eligible to be entered into the trial, and that's because of lead bias. So you have to have all patients in the trial from that point onwards rather than before. So, I mean, it's a lot of time I've spent with the risk, but I'll tell you how we stand. I'll offer the prognostic biopsy. I'll tell you the risks and benefits. I may not spend so much time on the risks, but if patients want biopsy, we'll do it. But we will support from my experience, we realize we need to support the patient with a negative biopsy more than the ones with the ones who have had a bad prognosis than one with others. Then we'll discuss the treatment modalities. We keep up our skills. We know that at some point we'll need to do biopsies on these tumors once our adjuvant trial comes. But what we also don't know is that whether you need the biopsy of the primary site or whether you need biopsy of the liver site. Because in our conjunctival melanoma study papers or our experience, what we found out is that even if the conjunctival melanoma is BRAF negative, the metastasis may be BRAF positive and it may be eligible for trials with some other drugs. So realistically, this biopsy of the tumor may not be adequate. You may actually need the biopsy from the metastatic site. So there's a lot of information, okay? So there's still a lot of people who want this biopsy done, and we will do it for you. But you need to go in this, aware. We've had patients 15 years later after biopsy who have metastasis locally or spread locally. So the question is, you need to be told this information. That's one big thing that came out of the melanoma guidelines is pros and cons should be discussed, and we've improved that over the years, how we discuss with our patient. I know perhaps I'm just going to ask you, with this information, how many would still have a biopsy? Yeah, great. So we're still looking at 50% or something. So what you have to remember is that we have self-selected group. You're all here because you want to know. And there are people who may not come to this conference because they just don't want to know. They want someone else to take the treatment and make that decision for them. So not everyone wants a biopsy, but we'll do it when we need to. The last bit's about surveillance, and I've been shown the 2 minutes card already, so I'm going to stop just by saying about supraradial MDT. We have an MDT. We're grateful to all our big team. We have colleagues across from Southampton to Leicester to Birmingham who we send patients to if they need any treatment which we can't offer in Sheffield. And about surveillance, we decide on an individualized plan. You will get a nurse, you'll get a physician who will look after, and it may not be the oncologist at the moment because of funding issues. We're looking at another ocular oncologist, It may be that our ocular oncology team may look after the surveillance, but the moment there is a risk of spread on ultrasound, and we'll get involved. We'll get the liver surgeon and the oncologist involved. What's the future? Well, we've got a national fellowship, looking at an international fellowship. Our research and publication profile significantly increasing. I was with Paul Finger last month, and we're looking at an international registry on intraocular lymphomas as well as conjunctival melanoma. So there's a lot of collaboration we're doing with national and international centers, and hopefully targeted therapy, which I'm hoping I'll learn more from in the next few talks, and adjuvant chemotherapy trials will come. And I really hope we can continue this interaction between OcuMel and us. Thank you.
Thank you for the talk. Does everyone have any questions for for Mr. Salvi. Yeah. Oh, sorry.
Your patients, you were looking at your patients on follow-up, comparing your ultrasound and MRI. How many? You said you had difficulty in recruitment. How many patients have you actually followed up?
We've got 8 at the moment.
8?
8, yeah.
Okay, so not very many so far. But there must be figures from other tumours, because this is something you can determine on any tumour, I think. So there must be huge numbers of patients, say with ordinary melanoma, which also metastasise to the liver, that this kind of comparison has been done. So there must be an answer known to this question.
I wish.
And I might say that you have also mentioned that your access to the MRI is difficult. So obviously what you do is governed by access. So what about places like America, where for insured people there's no problem with access, because if you've got the money, you've got the test, you know.
Okay. So you've got 2 points is about other tumours. What we know is that ocular melanoma tumours behave differently to, say, colonic tumours which spread to the liver. From our experience, and there's a paper coming out shortly soon, what we know is that contrast enhanced MRIs, things like that, don't pick up tumours because of the way the melanin content in these tumours is. So these tumours, ocular tumours, behave differently on the ultrasound characterization versus MRI characterization. Oral ultrasounds are reported and are looked after by a trained radiologist, Tony Blake, who talked a couple of years, 3 years ago here. And again, we are comfortable with the fact that at the moment ultrasound picks it up pretty much as quickly. We found that one person did get a pickup on the MRI, and that's what we're saying is, if you do find that the MRI picks up the uveal melanomas quickly, then that's what we'll offer. The question about access to MRI is to do the fact that we find it difficult to do, say, Prof and me run the clinic together. We will find it difficult to do 14 MRIs on the same day. It's about the same day rather than access 2 weeks later, 3 weeks later. It's about a patient who comes from Devon who gets an ultrasound, because we can do these 14 ultrasounds on the same day, but we can't fit in 14 MRIs. So the access is to do with the day rather than 2-3 weeks later. Sometimes some patients, again, we offer them, we'll do them at the time of surgery because they come in for surgery anyway. So it's just trying to get resources, trying to make best use of the resources at the time. So if MRI shows, and I've discussed this hopefully if we get this off the ground, then my colleagues in Clatterbridge are keen to look at a bigger study looking at this, and we might be able to answer this question better soon.
There were 2 points I was a bit unclear on. You said 25% regret if they have bad news. Well, isn't that normal?
Yeah.
I would expect if we were given, we all need time to adjust to a new reality, and surely, that would be a normal human response.
25% regretted, this is from not our paper study, this is from elsewhere. 25% regretted having the biopsy, not having the diagnosis of melanoma. 25% said, well, I was hoping to have the biopsy, hoping it's good news. Yes. I've had the biopsy and I've been told that there's a high risk of metastasis and I just can't cope with it. I wish I had not known.
Well, that is normal.
That's fine.
I would have thought really. And the other thing was I was very unclear on what you said about the oncologist appointment that we're all meant to have.
Oncologist appointment?
Yeah, because you said you weren't going to get it with the oncologist that you normally use, or...
Okay.
What is it?
Yeah, sorry, I had to shorten my talk at the end only because of time reasons. We didn't really talk much about surveillance and the MDT. So the way we deal with our patients is that we had a metastatic melanoma pathway meeting involving the 4 centres in June in Sheffield. So we had representations from London, Glasgow, looking at what's the best way to actually get a pathway established, and hopefully we'll come out with a paper again very soon on that. But essentially, each centre would do it differently. Yeah. So from our centre, what we believe is that someone needs to take charge of making sure our melanoma patients get 6 monthly scans done. Okay, whether you want ultrasound or MRI. In London, there's a clinical nurse specialist who's working with the oncologist who deals with that. In Sheffield, we've got Ronan Leslie who takes charge of that. and we're looking at getting a coordinator who will look at that. In Liverpool, there's a coordinator who will make sure. So not every patient will see an oncologist the moment they're diagnosed with the melanoma. Okay? We will discuss these patients on the MDT. If a patient wants to see an oncologist, because the information that the oncologist will give, we're able to provide the same information because there's no adjuvant trials at the moment. If someone gets on ultrasound a suggestion that there is metastasis, these patients will be discussed at our MDT, where we've got the oncologist on the MDT and we've got the liver surgeon on the MDT, and these patients will get appointment to see both of them while they're waiting for an MRI scan of the abdomen, as a MRI scan as well as a PET scan. So when they see the liver surgeon as well as the oncologist, all the information is available to them that yes, whether there is metastasis, the staging, whether it's definitely metastasis, whether it's in the liver or whether it's everywhere. And then the decision will be made by these two together, whether to go for liver-directed surgery in terms of surgical intervention, which Ali Majid will do, whether it's a laparoscopic examination, biopsy, radiofrequency, local resection, or the oncologist will get involved with, whatever, ipilimumab, any treatment options that may be available, and they'll discuss the trials. I think one thing I've learned. Yeah, sure. The guideline was asking for an oncologist appointment. You have to understand that, we don't have the number of oncologists who will do that because we're getting funding to get another oncologist who will discuss that. So at the moment, till we get funding, that discussion is done by us. So we're increasing our workload of discussing what their oncologist would have discussed. So of the 200 melanoma patients a year who get diagnosed with uveal melanoma, it will be 50% of them who will, or 30% of them who will see the oncologist. The 70% will get follow-up and be looked after me, but no harm will be done. But there is access. If someone says, I actually do want to see an oncologist, and if he's from Birmingham, then the local oncologist will see the patient. From Oxford, the local oncologist will see the patient. We have no problems with that, but in Sheffield at the moment, the discussion is done by us.
That's great. Thank you very much. So we're running slightly late, so we're going to hand over. Well, thank you very much for your talk and for answering those questions.